All right, so today we're going to be talking about how the Medicare annual wellness visit can really serve as a gateway to implement the four M's in primary care. I'll focus both on the why and the how, especially a practical workflow strategies. So I have no financial disclosures, but the work that I work on is under the HRSA grant called the Geriatric Workforce Enhancement Program. We've had this grant since 2015, but the current cohort has been going on since 2025. So we're in our second year to date. So here's our objectives today. I'm hoping you'll be able to clearly describe what the annual wellness visit is meant to do, how it connects to the 4Ms framework, and most importantly, how do we actually implement this in real primary care settings? Again, who we are, this Health Resources and Service Administration supports these 42 geriatric workforce enhancement programs. The Dartmouth Geriatric Center of Excellence has an awarded one of these grants. Again, we've had one for numerous years now. And underneath our Dartmouth GWEP, we have four main strategic points. The far left being the one that I'm presenting today, and this is on a geriatric interprofessional team transformation in primary care, which is a mouthful, so we call it GET PC. We also do this in skilled nursing facilities. We provide professional education and training programs to medical staff as well, including MAs and nurses and physicians and residents. And then we provide a lot of patient education and training program services as well under this grant. So the Get PC program has been a Dartmouth GWEP initiative program. It's really focusing on the quadruple aim, which you see on the right-hand side, where we're trying to improve patient outcomes, improve provider work-life balance, reduce healthcare costs, and enhance patient experience. And we do this through four Medicare reimbursable codes. We do this through the annual wellness visit, including a nurse-run annual wellness visit, which we're going to hit on a little bit today, transitional care management, chronic care management, and advanced care planning. Since having one of these GWEPs starting in 2015, we've been in 8 states, 60 different practices, 18 different federally qualified health centers. We've had multiple publications, multiple national presentations. And if you notice, Georgia is in yellow there. So Georgia, the Georgia Memory Network is a state budgeted program, and it uses our Get PC program to help screen for memory concerns across the entire country. Dr. Flaherty, who is my boss, is also the co-principal investigator for the Geriatric Workforce Enhancement Program Coordinating Center, which serves as a strategic resource for HRSA and all the GWEPs combined. So our GWEP actually helps support the other 42 GWEPs as well. All right, so that was sort of the background of who we are. Now I sort of want to step back and talk about how we actually explain the Medicare annual wellness visit in a way that makes sense to clinicians. So we think about our vehicle inspection, which we have to do every single year. I'm not sure if everyone on the call has to do this, but it's pretty popular across the country. So every single year, we got to take our vehicle in for this inspection, and there's all these little components that have to be checked off. There's some nominal cost to the person, and you have to go to somebody who's certified to do these inspections. And you notice here's the mechanic. He's got his checklist there, and he's checking off all the little components that he's evaluating. And notice he does not have a stethoscope, but if he discovers you need a brake job, they give you the brakes for free, right? No, they do not. So to me, this is the Medicare annual wellness visit, right? So instead of a nominal cost, the annual wellness visit is actually free to patients. There are all these components that we have to check off. No stethoscope is required for the visit other than taking a blood pressure if you're still doing those manually. And if the patient needs a brake job, we cannot give them the brake job for free. So just so we're all set on some of the terms that we'll be using, here's some definitions I want to go over. First one on the top is the Medicare wellness visit. This includes sort of the welcome to Medicare visit and the AWV initial and the AWV subsequent. So the welcome to Medicare visit, or the IPPE, it can only be done within the first 365 days of somebody being enrolled in Medicare Part B. After that, you would go to the AWV initial, which is just the first annual wellness visit you provide a patient. And after that, it would be an annual wellness visit subsequent encounter. And if you notice, these all have to be at least 1 year apart from each other. So, and if the patient opts not to get a welcome to Medicare visit, you cannot do an annual wellness visit until at least after day 365 day. So you cannot do the annual wellness visit within that first year. That's what the welcome to Medicare visit is all about. And also included in all these visits is the health risk assessment, which is really the AWV questionnaire that helps guide this visit. So we're going to take a look at some of the health risk assessment requirements. So Medicare gives us this list and says we have to address all these things. Now, if you notice in the left-hand column, demographic data and health status self-assessment is in blue. And Medicare does not specifically identify what questions we have to ask, but states we should look at the CDC's framework for patient-centered health risk. And if you look at that document for demographic data, they say age, gender, race, or ethnicity. Now, again, most of our electronic medical records have those components in it, so we don't necessarily have to ask about it because they are part of that. But then the CDC's framework also says for health status self-assessment, you need to ask about health status, memory, and physical functioning. Now, mind you, they're a little vague. What does health status mean? And that's a great question. So we're going to talk about that a little bit going forward. But Medicare does say for psychosocial risk factors that you need to ask about depression and life satisfaction, fatigue, loneliness or social isolation, pain, stress, and anger. And the same thing for the behavior risks in the second column. Medicare says we have to hit on each one of those topics. I'm going to come back to social drivers of health in a minute. If we move to the right-hand column, the ADLs, or activities of daily living, and the instrumental activities of daily living, Medicare says we have to hit on each one of those components. If you notice, the social drivers of health is in this, I guess it's a pink color. Right now, social drivers of health or social determinants of health, or whatever phrase you need to know it by, is an optional element of the annual wellness visit. This came about 2 years ago, and we thought that in 2026 this was going to become a required element for the annual wellness visit. But I think given the change in our administration and president, that this has sort of been put on hold. But right now, these are optional components of the annual wellness visit. So then during the visit, here's some additional requirements. So Medicare says, looking at the first column on the left-hand side, that we have to establish family history that includes parents, siblings, and children, past medical and surgical history, medications, supplements, allergies, a list of current providers, and then you can see those continue going down to basic vital signs. But if you notice screening on the first column, I have highlighted in the health risk assessment. So Medicare says you can either ask a question about that or do direct observation. So here in the Dartmouth network, we do both. So we ask the patient if they have concerns about their memory, but we're doing a mini cog on every single patient. And then if they score under a 3 on the mini cog, then we would go ahead and do a MOCA. And the same thing for depression. We are asking the PHQ 2 to 9 during the health risk assessment. So we wouldn't necessarily add that into the visit because they are being done in the health risk assessment. You notice the same thing with the middle column here, direct observation or screening. We have the ADLs, and again, you saw before that we're asking the question. Falls assessment, we are asking the study algorithms falls questions. Have you fallen? Are you afraid of falling? And do you feel unsteady? And any patient that screens positive for that, we are doing a 5-time sit to stand during the actual visit itself. For hearing impairment, we're asking a question. Home safety, we're asking a question. Then Medicare goes on to say we should establish a written screening schedule. This is really sort of the healthcare maintenance tab. So if your electronic medical record has a healthcare maintenance tab, that's what we're looking at here. Then you're supposed to establish a list of risk factors with recommendations. So here, if they were at risk for a falls, we might make a referral to a Tai Chi Quan Moving for Better Balance program or a referral to the Aging Resource Center for further evaluation. On the right-hand column, you'll notice provide that personalized health advice, sort of what we were just talking about. Provide advanced care planning. So in non-federally qualified health centers, you can provide advanced care planning and you can actually split bill that. We're going to talk about that in a little bit. In an FQHC, a federally qualified health center, advanced care planning is incorporated into the annual wellness visits. You do not get to split bill for that. So Medicare goes on to say we also need to review current opioid prescriptions and screen for potential substance use disorder. You notice a big red statement down across the bottom, a head-to-toe exam and management of acute and chronic conditions is not covered under the Medicare annual wellness visit. So if we talk about some of the opportunities and misconceptions around the annual wellness visit, first of all, the opportunity. There are a lot of Medicare patients out there. There's approximately 67 million Medicare patients. The Medicare annual wellness visit continues to remain underutilized nationally. And the annual wellness visit is often misunderstood by clinicians and patients. So if we look at the little chart on the bottom there, we talk about the misconceptions that it's just paperwork. In reality, the annual wellness visit is a structured preventative care. The second column, second row rather, that the misconception is the annual wellness visit duplicates visits. So the annual wellness visit is actually distinct from an evaluation and management visit. They are two separate visits. And it's hard to fit into workflows. And really, if we're talking about a team-based opportunity here, that can really help bridge that gap. So the reality of the annual wellness visit, as I sort of already alluded to, it is a free visit to the patient. This removes the cost related barriers to the patient. So they owe nothing for this visit. But if you split bill it and they get a bill, then there could be some patient dissatisfaction with this because they thought they were coming in for their free visit. So you really need to make sure that we have good communication about that visit type, and we're going to talk about that in a couple more minutes as well. So there's also some studies that show that the annual wellness visit was linked to reduced Medicare spending for 24 months following the annual wellness visit, and that the annual wellness visit improves the uptake of post-visit preventative services. These are services that your facility may already offer. And again, billing opportunities there. The assessment is geared towards the needs of older adults. This is going back to the age-friendly health system, which we're going to talk about in the next slide. Screening for cognitive and mental health concerns, as well as physical functioning, really important in older adults, obviously. and a patient's opportunity to engage with their care team, right? So most of our nurses are doing triage phone calls and may or may not have ever met this patient in person. So if you're doing a nurse run visit, this is a great opportunity for the nurses to connect with the patient. And then if the patient calls, then the nurses already met this patient in person. And a great opportunity to connect to community-based support and services. So here's a pictorial of the age-friendly health system, which was created by the Johnny A. Harford Foundation and the Institute of Healthcare Improvement. And it really focuses on this 4Ms framework. What matters to the patient? So here you're really looking about advanced directives and what's important to the patient, right? Healthcare providers are great at infusing my concerns towards the patient, but what is the patient really worried about? Medication, here we want to really look to make sure they're not on any high-risk medications, including the Beers criteria, if this is something that you work with in your institution. Mentation, again, looking for cognitive decline. Some people also call mentation mind because we also do screen for anxiety and depression during this period of time as well. And then mobility is really all about falls and abilities to do your activity of daily living. So this is sort of the framework. Now, the IHI, the Institute of Healthcare Improvement, does allow clinics to get certified in age-friendly care. And there's two levels currently. There's a level 1, which is a participant level. And at this level, you're really identifying how you're going to incorporate the 4Ms into your practice. And the best way to do this is naturally through the Medicare annual wellness visit because it does hit on each of these 4Ms. So just by indicating that you have this initiative to increase the number of AWVs, you are meeting a level 1 age-friendly health system. And then level 2, the commitment to excellence, is really where you provide some data. Now, again, the Institute of Healthcare Improvement has been sort of easy for this because you could, in theory, show that you've increased your number of AWVs and as a proxy, the 4Ms. So great opportunity for your clinic to become age-friendly health system just by doing the work that we should be doing during the annual wellness visit anyhow. And to take a little bit better look at this, here's the 4Ms and where they're incorporated in the annual wellness visit, looking at the far left-hand column, the what matters. So this is about advanced care planning, sort of health goals for the patient, functional priorities, and asking the patient what matters. So interesting enough, we're publishing a paper on this whole concept right now. And it's funny, some of the examples of what matters to the patient. You know, we get a lot of the people that say, I want quality of life and not quantity of life, or spending time with family. But it's surprising how many patients come out and just say, I want to watch Jeopardy every night. Okay, well, that's your goal. We'll do what we can to get you to watch more Jeopardy in life. So it's really amazing what you find here. And also in models where we have a nurse-run visit and maybe a split visit where the physician is coming in after that visit, when the nurse relays this information to the physician, a lot of times they're unaware of these things because competing priorities, the clinician never really gets time to ask what matters to the patient. When we talk about medication, polypharmacy is one of the things, but so are the high-risk medication, the Beers criteria that we talked about before. And also the annual wellness visit is a great opportunity for deprescribing, taking medicines away that are no longer needed. It's amazing how many medications can build up over time, and reassessing whether or not these are still appropriate is a great opportunity to do that during the annual wellness visit. When we talk about mentation, again, you could also think of this as mind. So we have our depression and anxiety screening through the PHQ and GAD tests, and then cognitive screening through MiniCog, MoCA, or SLUMS. In our clinic, every patient who has Medicare or any patient over 65 automatically gets a mini cog. If they score less than a 3 on the mini cog, we go ahead and do a MOCA during this time. For mobility, we have recently switched to the 5 times sit to stand. We used to do the timed up and go, but one of the issues is to do the timed up and go, you really need 10 feet. Unfortunately, I don't have 10 feet in my exam room. My exam room is smaller than 10 feet, slightly smaller than a prison cell. I don't know if that's their way of controlling me, but so anyways, so we have switched to a 5 times sit to stand. The other benefit of doing a 5 times sit to stand is this can be done remotely. So if you're doing these visits through telehealth, you can do a 5 times sit to stand telehealth. And then obviously we have our other gait and functional questions as well. So when our team sat down and really thought about a high-level workflow in a non-FQHC, so a non-federally qualified health centers, we would start off with the scheduler would book the annual wellness visit, and during that time, the health risk assessment would automatically get queued for that visit type, and it would get released to the patient 2 weeks prior to their visit. So, because I live in the perfect world like everybody does in healthcare, the patient's compliant and they complete the health risk assessment via the patient portal. So they're coming to their visit with that health risk already completed. I know that's a far stretch. Then the receptionist would arrive the patient and they would assess completion of the health risk assessment. If it has not been completed, they would give the patient a tablet to complete during the while they're in the waiting room. Then you have the rooming staff would also assess the completion of the health risk assessment. If for some reason the tablet didn't get assigned or the patient needs help completing the health risk assessment, then the rooming staff would go ahead and do that. The rooming staff would go ahead and room the patient and update the chart with some of the AWV requirements. This could be some of the family history. This could be the care team. So depending on your workflow, there would be some updates here. Then the nurse would come in and open up the AWV template. They would complete all the requirements under this direct supervision. They would complete the note, the code, and bill the visit. So this under direct supervision in non-FQHCs, the nurse can do this visit independently. The physician or advanced practice provider does not need to come into the room. They can complete this all on their own and bill it under incident to a physician who is in the suite and is readily available but does not have to come into the room. So then here the patient would go to the exit secretary and they would manage any referrals and follow-up visits, including next year's Medicare annual wellness visit. When we talk about what this visit looks like in federally qualified health centers, it's sort of the same concept, going all the way up until the nurses component. So here the nurse would open the AWV. They would complete all the AWV requirements under the same direct supervision. But here in a federally qualified health center, an authorized billing provider needs to come in and have a face-to-face visit with that patient at some level. Then the physician would complete the note, code, and bill, and then the exit secretary would manage the referrals. When we talk about the annual wellness visit in FQHCs, we talk about a dental model. So when you go for your dental cleaning, the dental hygienist comes in and does the majority of the work, and the dentist makes a guest appearance at the side, checks your lymph glands, and asks you to move your tongue side to side. But if you need a cavity, the dentist doesn't drop what they're doing and grab the drill and starts filling the cavity. They make you come back and fill that cavity at another time. So in this workflow, when we first started working with federally qualified health centers, we sort of had it laid up that way. The patient came in for the annual wellness visit originally, and then a month later would see the primary care provider to talk about their knee pain and their congestive heart failure. But what we come to find out, there was actually a lot of pushback and a lot of stress by the provider. When the provider would come in at the end of the annual wellness visit, they felt obligated to manage whatever acute and chronic issues might have come up. So currently when we're working with federally qualified health centers, we're reversing this flow and it's actually working much better. So here, the clinician would see the patient for their management of their chronic conditions and do a warm handoff and tell the patient, hey, I want you to come back in a month and I'd like you to do this annual wellness visit with my nurse, and I'll pop in at the end just to let you say hi, but I won't be addressing anything during that time. And hearing that from the clinician itself, the patient understands and is more open to the procedure. So this is how the workflow sort of differs in an FQHC versus a non-FQHC. So over our 10 years of experience, we really figured out some of the top levers for optimizing the annual wellness visit. If we start over on the left-hand column, it's education and shared understanding. So first of all, it's patient education. Going back to 2015, Medicare used to deliver booklets to other Medicare patients. The annual wellness visit had one paragraph in it in this booklet, one paragraph about this whole complicated visit. So it was not very good. Now, the section on the annual wellness visit is much longer, but the problem, so is the book in general. No one reads these things. So the patient education really needs to come from the clinician and really focusing on that this is a preventative visit and not a physical. Also, clarifying the scope of additional billing in a non-FQHC. So if we do more stuff, if I give you a break job, I do have to pay you for that. And then staff education, including the front desk, medical assistants or rooming staff, registered nurses, and providers, just so everyone understands what is and is not the annual wellness visit. And we talk about sort of this interprofessional team-based model. This is a great way to free up things for the clinician itself. So first of all, defining the role clarity during the rooming process. So who's doing what? So the medical assistant or the rooming staff, we expect to do the mini cog. And the nurse, if needed, could go ahead and do the MOCA. The falls assessment could be done by the rooming staff. So just really understanding these different models is really important. And the other thing we have created is standardized orders. So basically, we created this nurse protocol worksheet. So for every possible finding during the annual wellness visit, there's an action plan of what the nurse can do. Now, some of these action plans could be that the nurse needs to book an appointment with the doctor, but some of it could be they could make a referral to the Centers for Aging for a falls assessment without ever even including the doc in that decision making. So having this protocol is a great idea. The health risk assessment, as we talked about before, we really have to make sure we have these required components. We really want this thing completed prior to the visit, either a portal or a tablet. This health risk assessment should take no more than 20 minutes. So adding 20 minutes of time into the visit to go over this health risk assessment is really going to kill the visit time. For some providers, they may only be getting 20 minutes to do this or 30 minutes. So to do that health risk assessment during the visit really doesn't work. And how do we integrate the findings of the health risk assessment directly into the electronic medical record field? So there is no retyping it, there's no scanning it, it automatically gets imported. Speaking of that, really, how do we optimize our electronic medical record? One of the key components here is really using the tools that you have available in your electronic medical record to the best of their ability, using a bunch of smart link or smart phrases. If you're a clinic who's using ambient listening does a great job, especially with the after visit summary and the care plan for the patient. It does an amazing job with that. And reporting tools, how to identify patients that are due for an annual wellness visit. So really utilizing your electronic medical record. Billing integrity and expanded value. So again, in non-FQHCs, we can split bill the annual wellness visit with evaluation management codes, with advanced care planning codes, with the G2211 where appropriate. but really making sure that our documentation aligns with the reimbursement and that the patient is aware of any potential split billing that's going on during the visit. Here is a note template that I created in Epic. This is currently a system-wide template for the Dartmouth network. And if you notice the template under almost every component, like list of current providers and suppliers in that first box on the left-hand side, my note template says, update this in the care teams tab. I don't want you typing this in the note. I want it to stick permanently going forward. So update that. And then you can see my use of smart phrases. So that at patient care team, that just goes ahead and pulls in the care team based on that information you just put in at the top. And the same thing with problem list meds, social history. I'm updating that in the electronic medical record. Even advanced directives is just going and finding their advanced directive status. You'll notice my first free text box is what matters most to the patient. And so here I would do a little bit of typing, minimal, hopefully. And then when we look over on the right-hand box, you'll also see a drop down. So an opioid prescription was or was not identified on the medication list and so forth. The same thing for the Minicog and Mocha. Our rooming staff is entering this in a flow sheet, not typing it in the notes. So this way we can track it over time and look at history versus having to go through 100 notes to try to find out where we documented the Minicog or Mocha. The same thing for the 5 times sit to stand. And then under the health risk assessment, that at HRA just brings in the health risk assessment and brings in our vitals, including the last 3 blood pressures and last 3 weights, just so we can sort of take a look at how things are going. And then as we get to the bottom of that box, you'll see the at HM list. That's the health maintenance list. So that's going to list, the last time they had their colonoscopy and the next time they need to have it. And then this is always debatable, but looking at the cholesterol, A1C, and 10-year risk factor for having a stroke or heart attack. Again, this is all being brought in from the electronic medical record. I've done no typing. And the only part then going towards the bottom of this note is where I'm typing my personalized health advice. And we have created smart phrases for every possible finding, which is great. So if they were at risk for a falls, I would do AWV falls. And so that would bring in my plan for my note. When we look at the after visit summary, we would use smart phrases here. Again, down towards the bottom, you see here, I would use the smart phrase .avs falls for after visit summary falls, and it would bring in this statement here, including links to national organizations that are patient facing to help a patient better understand what's going on there. So this is just sort of a sample of what our template looks like in the Dartmouth network. We've created similar templates in numerous different EMRs over the years. So let's talk about a case presentation here now. So unfortunately, I'm having trouble seeing the chat. Let me see if I can, I can see the chat now. So let's take a look at this case presentation. So this is a 78-year-old woman who presents for an annual wellness visit. You can see her history there. She's got hypertension, diabetes, osteoarthritis, and she's on 8 medications. The health risk assessment reveals she had a recent fall. She feels lonely. She has difficulties remembering to take her medications, and she wants to stay independently at home. So what additional assessment would you perform during the annual wellness visit? And if you have access to chat, go ahead and put those in the chat. Come on, at least one person put something in the chat. There we go. A mocha, great. Other ideas? Thanks, Eminem. We have a PHQ GAD and another person who's on favor with the mocha test. All right. Quiet group here today. So when we look at this, oh, here it comes. Now we got some sit to stand, vital signs, sit to stand. Right. So here for this patient, I would do an additional functional assessment. So I would do a 5 times sit to stand. I would screen for depression using the PHQ. I would assess for anxiety using the GAD. Cognitive assessment, either a mini cog or a MoCA, and I see that comes across here quite a bit. And then a medication review, of course, since she's forgetting to take her medications as well. So I think all of these are great. So what four M's are present in this case study here? When we're looking at this, which four M's do you think are represented in this case? Go ahead and put your answers in the chat for me, please. What matters? Good. Mentation, mobility, memory, mentation, and what matters? Great. And, so of course, a trick question because the answer is all of them are present in this. We have the recent falls, we have loneliness, difficulty remembering, and wants to stay independent. So we've nailed all four of the four M's in this case. All right, so how could the care team address these findings using the 4Ms framework? So how would you start to address these findings? What would you do first? A little bit longer answer for people, but chat something in the chat would be wonderful. Make it look like I'm doing good here today. Find out, yeah, find out if she has support at home. Great. Yeah, just in clinic yesterday, I saw an 88-year-old woman who was in a wheelchair with oxygen. And I was like, who brought you here today? And she told me she drove herself. And I was like, who do you live with? And she lives by herself. So I got really worried about this ability to maintain her ADLs at home by herself. So ask what's most important first and in what order. I love that going first, the what matters to the patient. So great. So again, you nailed them all. So what matters, clarify the patient's goals. For medication, identify any high-risk medications and maybe deprescribe. She's on 8 medicines. Mentation, address her cognitive and mental health findings. So again, she's having difficulty remembering taking her meds at home. Mobility, so she had a recent fall. And connecting her to community-based programs is a great option. All right, sort of the key takeaways today. So the annual wellness visit is a preventative visit focused on risk identification, not disease management. The annual wellness visit is a gateway to operationalizing the 4Ms. The RN-led model can allow an efficient team-based delivery of the AWV. Separating the preventive and problem-based care can improve workflow and patient experience. And small workflow changes can lead to reliable, scalable implementation.